This is another slide I found, so I hope everyone, I don't know if people up the back would be able to see it that well, but basically what it talks about is that, now if I can use this cursor, so we can see that this is CBD, this is PSP here, and this is FTLD, so frontal temporal lobar degeneration or frontal temporal dementia. So you can see here, so here's the overlap between CBD and frontal temporal dementia, which David mentioned earlier. There's also an overlap between PSP and aspects of this disorder. So if we're talking about two diseases that have clinical and pathological similarities and overlaps to frontal temporal dementia, it made sense to me that we would be seeing similar behaviour and cognitive changes that we would see. So they may not be as severe, they may not be exactly alike, but if there's overlap, it makes sense that we would see something similar to frontal temporal dementia in a clinical way when we're thinking about cognitive and behaviour changes. And so what we're seeing here, not that you'll be able to see it that well, I apologise, is that it says non-fluent aphasia. So that's kind of a progressive language change, and that occurs in all three of the diseases. Tau inclusions and mutations, so that's the pathology that David was talking about. Changes to the basal ganglia occur in all three, as do frontal executive deficits, which we'll talk a bit more about, and apathy, although I prefer to use the term adynamia, which is a loss of drive and a loss of motivation, is also common in all three of these. Now, just with Parkinson's disease and MSA overlap considerably, but they're a little bit different to the overlap that you would see between these three. So I don't want to include MSA in this, that's why MSA isn't included here. But basically PD and MSA, so Parkinson's and MSA, also they have similar pathological features and are a little bit distinct pathologically because they have a different proteinopathy, and David mentioned that. But basically what they're thinking now is that MSA, and I'll talk a little bit about this later also, has similar frontal executive features, similar to PSP, but maybe more mild in the spectrum that we're going to see. That's what the literature seems to indicate. But basically, you know, the take-home point here is that PSP, CBD and MSA are rare diseases, and because of the overlap with frontal temporal dementia or Parkinson's disease, that they're often misdiagnosed. And so again, it's hard for us as clinicians to develop our clinical experience. And often when we look at the literature, particularly in terms of cognitive and behaviour changes, because the populations are overlapping and often so small, the literature can even be contradictory. So really what I want to present to you today is, I guess, more of the common findings in the literature and the more generally accepted types of cognitive and behaviour changes that you might expect. And just my last little rant about why I think it's okay for people to have, well, that we should expect people to have some kind of cognitive and behaviour change at some time in their disease process. So because, you know, we essentially know that there is neurodegeneration or cell death within the cortical, the basal ganglia, subcortical and other subcortical structures. So that's, I guess, my little rant. I'll leave that for now. So I think that really, you know, took home, really gave me the message that, okay, well, I think, as in other progressive neurological disorders, that if it affects the brain, there's going to be cognitive and behavioural impairment at some level. So just a bit about PSP. I guess this slide I just like to use because I think what I really like to highlight, and this also goes for the other disorders that we're talking about today as well, is that in progressive neurological disorders, symptoms unfortunately interact in a really complex and disabling manner. So when I'm talking about cognitive and behaviour difficulties, I also need to consider what else could be contributing to cognitive and behaviour difficulties, rather than, you know, cell death or difficulties in the circuitry. What else is going on for the person? Are they tired? When we're tired, we can't really think very clearly. You know, our concentration's not going to be as good. You know, our thought processes may not be as reasonable if we've had a bad day or if we're irritable. You know, somebody mentioned in question time, you know, what's the emotional implications for these diseases? Well, you know, grief and loss and adjustment. And if you're grieving or you're, you know, really struggling to adjust, then you may not want to engage socially as much as you had before. David mentioned the pathological laughing and crying, which is also called pseudobulbar affect. And, you know, is that reflecting, you know, is what we're seeing emotionally reflective of an organic change in the brain, or is it because someone is really feeling low and depressed? And I guess we as, you know, clinicians and health professionals need to be, you know, I guess working from a holistic perspective, looking at all of what's going on for the person as well. So I guess some common thinking and memory changes, and I'm going to use the term cognition, but really what we're looking at is that the speed of information and thinking is slowed, and this is perhaps probably, you know, the number one cognitive difficulty in the literature for people with PSP. And then as a result of that, we get a really long latency of responding, which is this, you know, you'll ask a question there and people need a lot more time to take in, process that question and then provide their answer. And, you know, sometimes seconds, sometimes minutes. But typically in PSP, people will get there accurately if you give them enough time. But I think it's also important to recognise that if you jump in and give someone a prompt or say, you know, how are you going today? Oh, are you having a good day? Well, that restarts their timer. So remember that. Okay, they need a certain time to process, and what we do, which is natural, is try to fill the gaps because you don't want to make people uncomfortable, or we struggle to deal with uncomfortable silences. But sometimes uncomfortable silences are necessary for people to get their point across. We're also looking at attentional and concentration difficulties, so people may be distractible, have difficulty attending to more than one thing at a time, may have difficulties with their working memory, and that's just really taking in information, processing it, kind of juggling it in your head, thinking about things, and in order for you to make an appropriate response. Now, learning and recall of new information, as David said, memory itself, so when we refer to memory, we're really looking at forgetfulness. People don't forget because forgetting involves the temporal lobes, and temporal lobes are, you know, they're relatively spared. They're spared in PSP. But what the problem is, if you can't attend or you're not given enough time to take in the information, it's going to go in inaccurately. You're going to lose some of that information on the way in. So what happens? It's going to come out inaccurately. So we're looking at unreliable recall of information. Okay, and that recall may be improved if you give people a prompt or a cue about how to access that information from memory. But it's not a forgetfulness like we see in Alzheimer's disease. So memory is affected, but it's the attentional aspects of memory. And that's something that people often can get quite confused about. Okay, and I guess some of the other issues are when people go blank in conversation or they lose track. And I guess just the other thing about recalling information can actually be, if you're recalling inaccurate information, people can think, unfortunately, that you're lying. Because sometimes the information's correct that you're providing, other times it's inaccurate. And this can really be frustrating for family members, you know, particularly if they said, well, I told you that. And you say, oh no, well, you told me this. And so you can see that there can often be, you know, a really significant source of frustration that emerges there. So, you know, even getting people to having, you know, couples write things down that they're, you know, that are essential and important is really useful. So we can have word finding difficulties, difficulties generating ideas, planning, organising difficulties. So these are the more executive difficulties that I spoke about earlier. So people being disorganised, jumping in. We can also have problem solving and decision making difficulties as well. And they can have significant, they can be significant issues for obviously interventions that you're doing and wanting people to follow up on recommendations. If they're not able to make appropriate decisions or follow through on those decisions, well, that's got significant inflammation. That's a significant factor for the therapy that you're doing if you're asking people to go away and do things at home and they're not actually able to do that because they can't get started or they can't complete the task or they can't decide which part of the task they should start.